Okay, thank you all very much for the invitation. I was invited by Dr. Esmaili and I heard she's ill, so I hope she will recover soon. Also, my thanks to Dr. Ceylani, who took over as a moderator. And I also want to greet Dr. Manouchian and Dr. Nietbacht. They are also on the first picture because I met them this year, a few months ago. I hope to see you all again and when I will visit Iran again. Because you are always very kind to me, friendly, helpful and nice, and I really appreciate it, and I hope to see you soon. Okay, let's start the presentation. My name is Annemarie Padmos, and as Dr. Samini told, I'm a Master of Advanced Nurse Practice in Pain in the Icacia Hospital. That's in the city in Rotterdam. It's hospital with about 300 beds. Okay, the content of the presentation will be introduction of myself, the definition of pain, the pathway of pain, acute, neuropathic and cancer pain. At the end, I will have 2 cases and I hope you will join the questions and answers because I have some questions in the presentation as well. Okay, this is me being in Iran. I have been there several times and I'm always very much enjoying Iran. Man ashege Iranam. Okay, this is the hospital where I work. My work consists of pain consultation for neuropathic pain, acute pain, patients with cancer pain, and also children. In Holland, we have a job, it's called nurse practitioner, and it's you are free to work independently of a doctor. And I'm seeing patients privately in the polyclinic or outpatient clinic, as you call it, also inpatient clinic, sorry. And I'm doing a full anamnesis, physical exam. I have to make a differential diagnosis and preparing a treatment with shared decision-making with the patient, and I am allowed to prescribe medication. This profession is, I think, around 15 years of history. This has a 15 years history in Holland, and in England and America even more, but it's a new kind of profession. This is the first page of my research. My research was post-hospital experience with pain management after a total knee replacement and the need for medication guidance. But we are not going into this one exactly. I'm keeping my presentation practical. Let's start with the definition of pain. Pain is an unpleasant sensory and emotional experience associated with or resembling that associates with actual or potential tissue damage. I'm checking first. Can you all hear me? Ben ik eruit?
Yes, we can hear you.
Okay, because
yes.
I lost your pictures. I only see my presentation, so I thought maybe you don't hear me anymore. Okay. The short version is pain is what the person says what it is. There's an additional note to the definition of pain. Pain is always a personal experience influenced by biological, psychological, and social factors. And I made some words red because pain is hard. It's not easy because of this personal experience. Everybody is different. Everybody shows his pain in a different way, and everybody has a different background and culture, and what the pain, how it's presented, you don't know. It's different for everybody. So you should take notice of that. Also, pain and nociception are different phenomena. Pain cannot be inferred solely from activity and sensory neurons. Also, without tissue damage, some people can feel pain. Through their life experiences, individuals learn the concept of pain. So you also start to be afraid of pain. You know some things will be painful and you already think, oh, that will hurt me. For instance, you don't put your hand on a heater because you will know it will be painful. A person's report of an experience as pain should be respected. So if somebody says, I have a lot of pain, and we think, well, that's a bit strange because in this situation, it should not be so painful. We still should listen to this personal report. Although pain usually serves an adaptive role, it may have adverse effects on function and social and psychological well-being. That's true because pain can change into chronic pain, and this will have a lot of influence in the life of a person with chronic pain. Verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. So if you cannot tell somebody that you are in pain, we should not ignore it. We should try to assess it in a different way, and I will come to that later. Effects of pain. Well, in the past we thought, well, pain is not so important. It's part of the deal. If people thought, well, if I have had surgery, I'm in pain. It's normal. They said children don't feel pain because the brain is not yet developed. Animals cannot feel pain. Things like this. Well, pain is uncomfortable, the quality of life is going down, the length of hospitalization will go up, and pain can result in all kinds of complications like pressure ulcers because of not moving, pneumonia because of not being able to take deep breaths, and slower recovery of wounds because the pain will induce stress hormones, and this will diminish the recovery. Pain can evolve in chronic pain and depression, and insurance prices of care go up. One of 5 people in Europe are suffering from chronic pain, and this will cost the community a lot of money. Those people are going from one hospital to the other to search for the reason for pain and for treatment. They take a lot of pills, take a lot of care, and it's a big problem. Well, we will see the pathway of pain. Let me see if I have a... First, you have the transduction. This is, for example, a needle stick. It will go to the transmission. Here is activation of the nociceptors. The transmission, it will go to the spinal cord, and from the spinal cord it will go up to the brain. And when the signal arrives in the brain, then we have the perception of pain. After processing the pain signal and the perception in the brain, there is a modulation going down. And this modulation is very important because it is affected by our brain and our way of thinking about pain, our learning. So the modulation will show you how much pain you will feel. Again, pain is influenced by biological, psychological, sociological, and behavioral issues. And that's why pain is difficult. Everybody
shows pain in a different way. Here you see some things, psychological things like mood, emotion. People can catastrophize the pain. Some people don't know how to cope with pain. Pain will cause stress, and stress has influence on the pain. Also, social support, occupation, education, income. If you are not well educated, you don't know how to deal with pain, you may be more worrying about it. Pain can have influence on your sleep. You sleep bad, you are more tired. Also, if you have bad life situation, you have bad, here is called diet, but if you are not eating healthy or you don't have a healthy health style, this can have influence on the pain and vice versa. Biological things like joint pathology, inflammation, genetics, and nociception, those are all things that have influence on the pain. One back. The anamnesis, I don't know how you call it, but the anamnesis is the questions you ask when the patient is coming to your clinic. And there are, in Holland, it's a nice word, but I had to translate it into English, and then this word is different now, but you ask about the characteristics of the pain. You want to know if it's nociceptive or neuropathic. You will ask about the location of the pain. Is it radicular pain? Are dermatomes involved or not? The severity of the pain. You can use the numeric rating scale. 0 is no pain and 10 is the worst pain ever that this patient can imagine. Oh, sorry. The chronology of the pain, how did the pain develop, how did it evolve, what happened. Also the origin of the pain, when did it start, where did it start, did it start with an accident or an operation, or did it gradually became worse? Oh, B, it has to be an I, the influence of pain on the quality of life. So what does the pain do to you, to your life? Can you do, a lot of people cannot go out anymore, they cannot walk because of the pain, they cannot go to a restaurant anymore, they cannot stand for a long time, walk for a long time, they don't sleep. It has a lot of influence. And also the opinion about the pain of the patient. Like some people say, oh, it's not so bad, it will go away, I have trust in this. But other people think, what is the pain doing to me? How long will it take? Is something bad happening to me? Do I have a dangerous disease or something? So this is also important because it influences the experience of pain. Well, some people cannot express their pain because they have an impairment in speaking. Maybe they don't speak our language. Maybe they have Alzheimer, dementia. They can have neurological diseases like aphasia. I don't know in English, but they cannot speak anymore. So we have a lot of other assessments. The numeric rating scale from 0 to 10, you can always explain to somebody and they can show you or tell you by fingers. If not, we have some kind of paper with faces, but I will show you. This one, the next one, the REPOS, it are 10 expressions of your face. You can use this one, you observe a patient for 2 minutes, and after that you can put 1 point after every observation. If you have more than 4 points, you know somebody can be suffering from pain. Those are all validated assessments. Also, we have the metric with faces. I show you later. And the last one is for people who are sedated or unconscious on the ICU. Those are all observational assessment tools for measuring pain if somebody cannot tell you. This is the one for children, and those are the faces who can show you how many pain somebody has. We have it in our uniform. It's like a lineal, how you call it? Lineal in English, I don't know the word, but it's a paper-wise thing. Okay, this is to help you to assess the pain in adults and children with disability to express themselves. Well, I hope you all know the World Health Organization steps for acute pain, because we are going now to the acute pain part. Acute pain, the duration will be less than 3 months. Acute pain is mostly post-operative pain or pain after an injury. It has an acute onset and a quick recovery, and you use the medication of the WHO. It's the World Health Organization, and this is the step. Mild pain is the first step, and you treat it with non-opioids analgesics like acetaminophen and NSAID. When the pain becomes worse, you take the first step plus the other step, and those are non-opioids like tramadol. And when you are in more pain, severe pain, you take the first step plus opioids. And most of the time, you can also use extra medication, but I come to this later. Post-operatively, you go the steps off. So you go down from the step. You start with this and you take away the opioids first when the pain is going to be less. And you end with the acetaminophen because it's the most safe medication from all. Okay, let's go to more into the medication. In Holland, we call this medicine paracetamol. I hope you know it too. I don't know what's the name of this medication in Iran, but we use paracetamol as the first step together with an NSAID. I put some names here. I don't know if you recognize them, celecoxib, atoricoxib, those are some examples of NSAIDs. And we use morphine, hydromorphone, oxycodone for fentanyl as opioids. Let's go into the paracetamol. It's quite safe. There are some no much side effects. Some people say they have stomachache from it, but there's only one contraindication, and that's severe liver dysfunction. So it's easy medication, and we always give it because some people say it doesn't work for me, but we will tell them and explain them, you take it together with the opioids, but you still have to use it. And we hope that if they use the paracetamol, the first step, we are taking less opioids. That's why. The next step are the non-steroid anti-inflammatory drugs, the NSAID, and they are contraindicated for a lot of people. For instance, people with blood clot disorders, stomach ulcerations, chronic bowel disease, diabetics, pregnancy, kidney failure or renal dysfunction, liver failure or renal dysfunction. So a lot of people in the hospital, they suffer from one or more of those comorbidities. So a lot of times we have to skip them. And then we have the opioids. The opioids in our hospital, because it depends. there are a lot of opioids, lots of brands, but we in the hospital we said it's important that we choose only a few. The nurses in the hospital will know this medication well, and so it's better for them to handle those medicines and to know the side effects, and they know the dosage. It's more safe. So we are using morphine, fentanyl, oxycodone, and hydromorphone, and the hydromorphone only is used by cancer patients, not for post-operative pain. The side effects are constipation, nausea and vomiting, dry mouth, sedation, dizziness, sleepiness, urine retention, and psychological dysfunction like depression, dependence, dysphoria, things like this. Okay, we have differences in acute and chronic pain. Those are shown here. Chronic pain or neuropathic pain, it will take more than 3 months. It's persistent, it has ups and downs, but it will stay with the patients for a long time, maybe forever. It's not reacting well on the normal pain medication from the WHO steps. People complain like the pain feels like numbness, tingling, burning, like creeping and walking insects. It feels icy, or like sharp needles, stinging, spasm. This is the description of the chronic pain. Acute pain will only take less than 3 months. It's quickly diminishing, and it's reacting well on the medication that we just called. And it feels sharp, like pressure or like an infection. It has a different description. Again, the difficulty of chronic pain. Chronic pain will give anxiety. It will give sleeping problems. Because we are not sleeping, we are not coping well with the pain, and the pain will increase. It will give more anxiety. Why do I have more and more pain? Why is it expanding? And so you are in a vicious circle that will go on and on and on. And I see a lot of people with pain all over the body. So it's very hard to treat, where to start and where to begin. And for them, it's also a problem because they don't understand why my pain is expanding. I didn't fall from the stairs. I didn't have an accident, but my body hurts all over. Here again, a different schedule. It starts with an injury, then you have the pain experience, and then you see 2 circles. The first one is the circle. If you go into that one, it's not so well. It's pain catastrophizing. So you have a bad way of thinking about pain. You are afraid of pain. It has, you also get negative effectivity of treating illness information, threatening illness information. So you also get bad information about the pain. You get scared, you are in fear and anxiety. Avoidance of things that hurt for you. Disuse of a leg or a hand, or you start to prevent the pain and you don't use, you are not going to move anymore because of the pain. You start to get into a depression, disability, or losing function of one or more parts of the body, and you are in a bad circle. The other way is you are not scared of the pain. There's a normal confrontation and there's recovery. So those are 2 models. What are the characteristics of neuropathic pain? I just called them paresthesia. Those are the official names of the stinging, burning, tingling, and numb sensation. Characteristic is that a dermatome is involved. You see here, the nerves have a dermatome on the body. So if somebody says, my arm is hurting and I feel it all over till my thumb, we use those descriptions to discover the nerve that is involved. So we have to think about nerve C8, for instance. Hyperopathy is pain when pain is not expected. Allodynia is a pain sensation of a non-painful stimuli like the wind or a soft touch. Like this is some kind of chart. If you use it, you brush with this and people experience this as painful, you can call it allodynia. Hyperalgesia is a strong pain sensation with a light stimulus like a sting of a needle, which will be feeling as extremely painful. And the opposite is that the hypoesthesia, like a painful stimuli, is not felt at all or less painful, like it's almost not visible, but this is one plastic fiber and you use it to sting people on the feet or on the hand. And if they don't feel it, you should be feeling it. If you are not feeling it, it's most of the time also neuropathic pain. And we see this in diabetics, people after radiation or after chemotherapy. Okay, medication for chronic pain. We use for different medication for chronic pain, and it will be medicines like anti-epileptica and antidepressants. And names for this in Holland, I don't know if those are brand names, but it's amitriptyline, nortriptyline, pregabalin, gabapentin. I don't know if you recognize those medications, but those are used for chronic pain, but also for people with epilepsy and depressions. But we use a lower dose. Because a lot of side effects from those medications, we slowly raise the dose and we start low. We start low and go slow. Very important is the explanation to the patient about the side effects, and also those side effects will disappear after a few weeks because a lot of people will stop in a short while with the medication if they feel the side effects. So you have to warn them and explain them to continue, and after 2 weeks those side effects will disappear. You also have to take them on a regular basis. So if it's written, if the prescription is like twice a day, you should take them twice a day and not only when you are in pain, like the other medication. Also, when after taking the pill, you will not be, the pain will not be gone. So people need to know this because they will tell me, I stopped taking them because I didn't notice any diminishing of the pain. So we should explain to them, you should go on for more than 2 weeks and then you will have less pain. Some people, they hear the side effects and they will think in their heads, oh, I will not take those pills. I hope they will be feeling free to tell you, because if I notice this and if I discuss this with them, I don't prescribe them because they will not take it, and it will be a waste of time to prescribe them and to push them because they will stop immediately. Also, it's important to know that a positive attitude of the caregiver influences the results of the patient. So the placebo and the nocebo effect. If I will tell them this will help you for the pain and I will be believing in this and giving them support, it will be helping more than if I say this medication can be useful, but I don't think so. Then the pill will not help them at all. So it's very important for the people who prescribe medication to have trust in this medication and be positive about it. Also the other treatments anyway. Here are some chronic pain treatments that we are doing in the Icasia hospital. There are more treatments, but we are a peripheral hospital, so those are our treatments. We give nerve block injections. This is a spinal cord. And for instance, this is nerve blockage of one nerve. You first need an MRI to see if there is a disc pushing to the nerve. We go there with a needle under radiology, and the needle will leave lidocaine and corticosteroids, and the corticosteroid will take away the edema, which has been which is here. This is one treatment. The advantage is it can help very well, but also after a few months the medication is gone and the effect will be gone also. So this is not a one injection helping for a long time, but it can help to recover from a herniated disc. This is the medication that I told you, the anti-epileptic and the antidepressants. This is a TUMS machine. It's the transcutaneous electric nerve stimulation. Those are plasters. You put them on the back or on the side where you are in pain, the neck, the back, the knee, it doesn't matter where. You place them in the dermatome, and then it's connected with some kind of box. If you turn on the box, there is an electric signal going through the nerves to the brain, and instead of a painful signal, it's a nice signal. So people like it when they have this. It's not like shocking things. It's a nice stimulus. Then we have the laser therapy. The laser light is not so clear, but this man here is the spot, but this light is going to make movements like this over in a special area where the pain is. The light is going into the depth of the tissue and taking care of less pain there. And then there is spinal cord stimulation. The spinal cord, it's an invasive therapy. It's needing surgery. They place in the epidural space, they place a wire that is connected with a battery, and this is giving signals in the back to the nerves for forever. It will stay there for you forever, and it's only helping if you have pain, not leg pain, not back pain. So it's not helping for your back, but it's helping for leg pain. Not everybody is fit for this. You need to be, there is a strict, indication for this. So a lot of people are excluded for this therapy. It's also a bit dangerous, and the battery has to be replaced every 5 years. So every 5 years you go back into surgery because the battery is placed under the skin. This is a small surgery, but this one is an invasive therapy, which is quite riskful also. Okay, chronic pain treatment out hospital is physiotherapy, which is always advised. Keep on moving, keep on doing your exercises, because if you stop moving, your muscles will be diminishing, will be stiff. You just need to go on moving, even if you have pain. Psychological treatment, some people are in need to give the pain a place in their life. Instead of your enemy, the pain must not be your enemy. It has to be your friend, and it has not to be the first role in your life. But it takes time to accept the pain is not going away. Acupuncturing and dry needling, we don't do it in the hospital. Well, the dry needling is done by the physiotherapy in Holland, but acupuncturing is outside the hospital. Some hospitals have it, but we don't. Revalidation therapy, how to live with the pain, and it's also done outside the hospital. Let's go to the cancer pain. Cancer pain mostly exists of a combination of nociceptive and neuropathic pain. Anamnesis is important to discover breakthrough pain is not a good word, it's a rapid onset pain. You need to take time for the anamnesis, think holistic, so ask about the pain, but also look at the total person, individual. The treatment of cancer pain consists of the WAO steps plus neuropathic medication or ketamine. We also pay attention to non-pharmacological treatment like massage, warmth or cold packs, the TENS machine, hydrotherapy, exercise, distraction. Those are all called non-pharmacological treatments. And we have the nerve blocks. Nerve blocks, some nerve blocks we are going into this, like chordotomy. It's a total dysfunction of the nerve. So the nerve is cut off by medication, by phenol. It's not in use anymore. So, and as you know, nerves are going to give us information, and it gives afferent and efferent information. So if you take it away, you must know it can never be recovering again. So we only do it when we know somebody is not going to recover anymore and will not be disabled after taking away this nerve. So it's definite. The plexus coeliacus block, you can do it in case of upper abdominal pain. The neuraxis blockage, it's intrathecal or epidural gift of opioids. And here you can see the place. This is the spinal cord. So, and the space behind it is the epidural space. So here, if you put medication here, it's in the epidural space. If you put it here, it's intrathecal, intraspinal. It's a better word. Plexus hypogastricus block. This can be done in case of pelvic tumors. The lower end block in case of perianal pain, but you should be aware that the patient will lose bladder and anal muscle function. So it's not easily done. You have to take this in mind. There are peripheral nerves. You can take them away in case of typical neural pain. You can take away one or two nerves. For instance, the nerves of the thoracic, the thoracic nerves. But there are advantages and disadvantages, and we are going there now. The advantages of a nerve block, you will be in less pain and you don't need as much opioids as you used before. So you have less side effects of the opioids. But there are lots of disadvantages. The nerve block is just a pain relief for one specific area, the area of the dermatoma. If the tumor grows, the pain will increase and the opioids are still necessary. There can be a failure of the epidural or intrathecal or spinal line or the pump, and then we have a problem. Special nerve blocks need special expertise, and it's not available in every hospital. So if we are not doing it as frequently as another hospital, the patient has to be transferred to another hospital, and the nerve blocks are only done in the last part of the life because it's definite, and it will be a lot of extra activity for a patient who is very sick. So also the coordination and the communication about the pump and the lines, and when there's an alarm or dislocation, is very hard. It can be done, but it takes a lot of work and energy. Also, when you take away one part of the pain, some other parts of pain arise. We should also take in consideration that becoming pain-free as a cancer patient, that's an illusion. And the blocks are only indicated when the life expectations are less than 3 months. So a lot of things to take in mind. How to recognize rapid onset pain. This is the cancer pain that is rapidly starting in a few minutes and mostly gone after half an hour. The reason for the pain, for this kind of pain, is not clear. It can happen 4 to 6 times a day, and it's a pain above the normal pain. So here you see a picture. This is the pain the patient always has, and this is the breakthrough pain or the rapid onset pain. And you should need special medication to treat this, and we use the fentanyl sublingual. The treatment is first treat the normal pain, use a rapid onset opioid like fentanyl. You should not be overdosing. A lot of people start to rise the normal pain medication, but then you are overdosing somebody because it's only necessary when they have the peak of pain. End of dose pain is like you take 2 times a day morphine slow release, and at the end of the time that the pill is working, you start to get into pain, and that's end of dose pain. Okay, now we are going into cases, and I hope you will join me because I will go and ask questions. So please unmute. And also I hope to see you, but I have to change my screen because I only see my own presentation now. Let me see if I can manage that.
Mrs. Padmos, there are 2 questions from the audience I'd like to ask. First question is from Mohammed Moin Tutesani. He asks why some sources say severity of pain is between 1 to 10, not 0 to 10.
0 means no pain, and 10 means a lot of pain. It's not invented by me. It's how they try to assess pain for people to help them, because it's difficult. When the pain sensation, if the number is more than 4, we should start pain medication. So from no pain to 4 is the cut-off number. So above 4, we should start pain treatment, and this is what all the nurses in the hospital know, and not only in our hospital. It's international way of assessing pain.
Yes,
and why they chose 0, I think 0 means no pain.
Thank you very much. Another question is that, can you prescribe opioids independently?
So I can prescribe opioids, yes. Is this the question? Because the last part I didn't hear very well.
Can you prescribe opioids independently?
And yes, I can. Yes.
Thank you.
Okay. Should we have a 5-minute break, maybe? I think that's good. Or not necessary?
Sure, we can. Thank
Yes,
you.
we
So
can.
we will have a 5-minute break.
Let's
and
take
then
a
we'll
5
be back after
Yes.
5 minutes. Yes.
Yes.
Thank you very much.
I don't know why I don't see my screen anymore. Oh, yes, I'm back again. I lost my PowerPoint. I'm seeing all the viewers now, but I'm not seeing my PowerPoint. So I'm searching for it, and then we can go on. I changed the settings of my screen, but now I cannot find how to go back. Let me see. Can you still see my PowerPoint?
No.
No, it's gone.
No.
Okay. Okay, I'm going to find it again. Yes. Oh. Okay. Can you see it now?
Yes, we can see.
Okay. Okay. We go on. Okay. The PowerPoint is in picture again. Okay. This is the first case. This is a 84-year-old male admitted in the hospital with general disease, malaise, we call it. He has more problems. He has a low body temperature. He's tachypnoic. He has a possible urosepsis, malnutrition, cachexia, pulmonal malignity seen at the CT scan. He has severe dehydration, renal dysfunction because of diuretics and because of the malnutrition and the dehydration. And he has liver function dysfunction. He uses very high doses of morphine slow release because of polyarthrosis. He uses 2 times 240 milligrams of morphine slow release and 6 times a day 40 milligrams of morphine immediate release. My question to you is, what do you think about the pain strategy, and why is it a good or a bad pain strategy? And I hope you will join me with this. So it's a question, and I hope you open your microphone and answer if you want to give some comment. If you feel insecure or about speaking English, it will be translated for you. What do you think about the pain medication for this man? Okay, I will go on. There will be more questions. Just feel free. It's interactive. The pain strategy is not so good because opioids are not indicated for malignant pain like arthrosis or benignant pain. It's benignant pain. Arthrosis is not malignant pain. So opioids are only indicated for malignant pain and not for arthrosis. Arthrosis is a chronic pain. Opioids are not very functional for chronic pain. It doesn't work as well. Using opioids for a long time, it can induce hyperalgesia. In this man, the doses are extremely high, so the side effects can accumulate. There's risk of sedation and respiratory arrest. we go on with case. Is somebody of you, can somebody name 3 side effects of opioids? Don't be shy.
As you said, some of them are like constipation, feeling nausea and vomiting, and dizziness or dry mouth.
Very well, very well. Side effects of opioids are nausea, vomiting, constipation, sedation, sleepiness, dizziness, having a dry mouth, urine retention, dysphoria, depression. Those are side effects that we see on a regular basis and the most frequent ones. Is it useful to taper the opioids in this patient, in this case, in this 84-year-old man? Why yes or why not? Do you have some arguments to take away the opioids from this man or not?
Because Leilani raised his hand, so if you can please turn on her microphone.
Yes.
Hello again.
Hello.
Thank you very much, Anne, for your very interesting and useful lecture as always. I want to ask Ms. Samimi to tell our audiences, anyone who wants to participate in the discussion and make this webinar more interactive, can use interaction in the reaction key in the bottom of the page, and then raise hand, and we can unmute the microphone to let him or her to participate in our discussion.
دوستان اگر کسی تمایل داره که شرکت کنه در سوال و جواب برای اینکه بحث جالب‌تر بشه، لطفاً اون گزینه پایین صفحه رو بزنید، قسمتی که دست بلند میکنن رو انتخاب کنید و ما میکروفون شما رو باز میکنیم برای اینکه بتونید صحبت کنید.
Ms. Sami, please repeat again in English because we have more, foreign audiences.
If you want, dear audience, if you want to participate in the presentation, please go to the bottom part and choose the raise hand section, and then we will unmute your microphone and you can interact and make it more interesting.
Okay. This said, I ask the question again because maybe it's more clear now that I expect an answer from the people, from the audience. Is it useful to taper the opioids for this patient, this 84-year-old male? Why yes or why not? With some arguments why. And it's not a right or wrong answer, it's a discussion. Okay, I go on. You have chance. There's a discussion. It's not useful for if this patient has a short life expectation. For instance, if he's only living for less than 3 months, we are not going to do anything about this. But it is useful when he has a longer life expectation, if he's suffering from side effects from the opioids, and if the opioids do not give any pain reduction at all for him. So those are arguments pro or against tapering the opioids. How do you taper the opioids? Because I suppose everybody knows that you just cannot stop opioids from one day to the other. This is very dangerous. It gives, you need to taper them slowly. Do you know the schedule of tapering down the opioids? Or how do you do it in Iran? Maybe somebody can tell me this. If you want to tell it in Farsi, it's okay too. It will be translated.
Dion?
Yes?
Since a prescription is part of your scope of practice, you are familiar with the different doses and how to taper these different kinds of medication. But at least for Iranian nurses, I know that it is we are not allowed. We are not allowed to prescribe any medication for pain, and so it's it's not strange if they don't know about the doses and the way to taper it. Thank you.
Okay, but even if they don't prescribe it,
Mr. Mahdi Shaibu, I think, raise his hand.
Okay.
Please unmute him.
Yes, you are unmuted now, please. Please speak.
Salam. Salam. Good day to you all. Can you hear me?
Mr. Mahdi, you are unmuted, so if you want, you can speak. بفرمایید.
Am I hearable to? Can you hear me? Am I hearable?
Yes, yes, we hear you.
Okay, about the opium stoppage, the taper. How we do it, it's not at once, just one time. We do it, we cut it down small by small, in small quantity, like in 10% first, then the next 20%, then 30%, then to the time we finish it all. But for the opium taping, we don't do it just at once.
Okay. Yes,
Yeah.
thank you for the answer. We have, I show you how we taper the opioids down. To increase them, we use a guideline, and it's 50 to 100% increasing every 24 hours. But tapering the dose, right, like you told us, 10 to 35% every week after long-term use. And the link under it, it's a guideline, but it's a Dutch guideline. Maybe it's international, or being able to translate it into English. Post-operatively, we cut it down quickly, like the use is only within a week, and then you cut it down 50 to 100%. There will be no problem. Thank you for your answer. The next question, how to treat chronic pain in the pain polyclinic or the outpatient hospital clinic? And this is not a question that maybe you are familiar with, but I presented it to you, so maybe this is to ask you if you paid attention. What kind of medication, for instance, do you use for chronic pain? Do you remember what I told you? Or the other treatments?
Yeah, you said we use NSAIDs or acetaminophen for chronic pain.
And what else? These are the medications for also for the acute pain, but for the chronic pain, we had some special medications.
Also physiotherapy, needling, and nerve blockers.
Yes.
The audience says that.
Yes, exactly. Okay, let me have a look. The exercising, physiotherapy, and I was referring to the neuropathic, like the amitriptyline, nortriptyline, pregabalin, those medications, the TENS machine, the laser, and the local injections and the nerve blocks. Very well, very good. This patient, does he has a reason for having neuropathic pain? And neuropathic pain is the pain that involves the nerves. Or does he has nociceptive pain? And the nociceptive pain is pain caused by tissue damage. This patient, what does he have? This 84-year-old man with liver, kidney function, lung malignancy, pulmonal malignancy, dehydration, polyarthrosis. What kind of pain is he suffering from? I know this is a difficult question.
Yeah, Mr. Mahdi says it's a nociceptive pain.
Okay, very well. Thanks for the answer. He has
and Dr. Ceylani mentions neuropathic pain.
Okay, I agree with both of them. He has neuropathic pain because he can have nerve compression caused by the tumor or by the degeneration of his spine, by the polyarthrosis, and he has a reason for nociceptive pain because there is tissue damage caused by the tumor growth. So he is suffering from both. What is a possible treatment when he is admitted in the hospital? What can we do pain-wise for this patient? We have to do a lot of things, but now we are talking about the pain subject. What should we do with this man when he's admitted in the hospital? What medication should we start? What can we do for him that will not be able to do at home, pain-wise? Let's check. We can start ketamine, esketamine. Do you know this medication? It's we use it because it has it blocks the NMDA receptor, and when people are in pain, this is a receptor that will transfer the pain into the brain, and if you block it, people will be awake, not sedated, but they don't feel the pain. So we use it for post-operative pain if the normal pain medication does not work, but we also use it with people with cancer pain that start to have side effects from the opioids, or we have the opioids in such a high dose that we add it to this. But you can only do it in the hospital because you need to give it intravenously. We can do an opioid rotation, and we will give the oral opioids into IV opioids, and I will ask you to think about why. We can start pregabalin for the neuropathic pain, and also after that, as a second step, we can also take an antidepressant to add to it if this is not enough for the pain. The next question. Why should we do a rotation of opioids from oral to intravenous? Oh, the answer is already there. The IV treatment is more quickly to adjust. Sorry, the answer is shown already. And the ketamine is blocking the NMDA receptor. Okay, this is a mistake in my presentation. Sorry for that. Next question. When should you think about an opioid rotation? When do you think about this? Do you have patients with opioids in the hospital?
Mr. Tutefsani wants to speak.
Yes.
Hi.
Hello.
I think for gather effect this treatment and shorter treatment is better. Is better. I think I forget my answer. I think that for effectiveness and shorter treatment duration, and it is better than who
Yes.
better than through self-medication and effectiveness is way.
Thank you for your answer. The sound is very soft, so I didn't hear very well, but thank you for reacting. Is somebody else?
Mrs. Dr. Ceylani also says when side effects are very obvious and problematic, we have to use rotation to another kind of opioids. And Samadi says observe side effects during the time and monitor its effectiveness.
Perfect. Yes, those are very good reasons to go into another kind of opioid. No more pain reduction and the side effects accumulate. Okay. What do you keep in mind when you rotate opioids? Where do you have to think about when you go from one opioid to another? Is somebody familiar with this? I think it's a difficult question. You have to decrease the equivalent dose with 25%, because when you change, you can use a lot of schedules for changing from morphine to fentanyl. For instance, orally, you check how many tablets, how many milligrams the patient takes, and then you go on to, for instance, hydromorphine, and you see 24 milligrams. And then we go to the IV, it will be 8 milligrams. But you take, for instance, 6 because you are going into a lower dose. Because when you change from one opioid to the other, sometimes the effect will be more strong, and that's why we go slower. We go lower. We decrease the dose. That's the rule. It's a guideline. Okay. And also to rotate this schedule, you can find it on internet, but there are a lot of apps on your cell phone that you can download to rotate the apps, and those are a few of them. So you can just put it into your cell phone and take the milligrams from the whole day and change to rotate the opioid. Okay, and this is a schedule how to rotate, for instance, from oral medication to IV, because you have to think about things. For instance, when you go from IV to topical, like a PET, fentanyl PETs, they work through the skin. 6 hours after the plaster, you taper down the IV pump 50%, and 12 hours later you stop the IV. So you put the plaster together with the pump for 6 to 12 hours, because the plaster on the skin works very slowly. So you cannot stop the pump and put the plaster. The patient will be in a lot of pain. So you have to take care of that. Okay, so this is a schedule how to go from topical to IV. Then you can stop the plaster and start IV, and you should be aware of overdosing. Those are some easy schedules to know. What are possible medical or nursing threats in this case? This 84-year-old man with malnutrition, pulmonary malignancy, kidney dysfunction, liver dysfunction. What should we take in consideration? Urosepsis. He had all kind of threats.
May I answer, dear Anne?
Of course.
I think based on our patient's age and the complicated condition of the patient, we should be very careful about the intake and output of our patient because of kidney dysfunction that you mentioned in the history. And also the liver function tests should be checked on a regular basis. And since our patients are under treatment with different kinds of drugs or receives multi, medication, we should be very careful about the level of consciousness of this patient, especially when receives opioids.
Exactly. Very well. Yes. Those are the problems that we have. The renal dysfunction, the liver dysfunction we should take care of. He has a risk of delirium, hallucinations because of the high level of opioids and also his age. The malnutrition, it will be bad for the dehydration also, but also pressure ulcers. And also the side effects of the opioids will increase because of the liver and kidney dysfunction. So he is at risk for having respiratory, for sedation and respiratory arrest. And also his pain will continue. When we will taper down the opioids, he can be suffering from detoxification, and some detoxification symptoms are dysphoria, insomnia, pain, tremor, sweating, being tired, nausea, vomiting, diarrhea. A lot of side effects are possible. What can we do in case of detoxification? For the pain relief, we are not going to give him more opioids, but we have to stay on the paracetamol, the acetaminophen, and the NSAIDs. Clonidine can help for sweating, the tremor, and the muscle spasm. Metoclopramide or ondansetron can be used in case of nausea and vomiting. Loperamide in case of diarrhea, and in case of insomnia, we should be aware that we should not prescribe benzodiazepines because of a new addiction. So it will be difficult. We have another case, the second case. This is a male of 45-year-old with metastasis from stomach carcinoma, and he is in extreme pain. His medical history is a fracture, a bone fracture because of a motor trauma, tibia. And in 2021, he suffered from COVID. The pain medication during admission in the hospital was fentanyl, 175 milligrams, slow release, a PET, a topical PET, and he used sublingual fentanyl for his rapid onset pain. Besides that, he used an NSAID and amitriptyline. The reason for admission in the hospital is that the pain is still not acceptable. What do you want to know, and what are the questions that you ask around the pain from this man when you are asking questions? What will you ask him? And I gave you already the schedule of questions, so let's see if somebody remembers this. What is the pain assessment you are going to do?
Okay. One of the audience, yes, Dr. Seilani says ask questions according to a table. Location, severity.
Exactly.
Yeah, like characteristics, and how has the pain developed, or the origin of the pain, and the influence of the pain on quality of life, and also opinion about pain of the patient.
Very well, exactly. Those are the questions, the characteristics. You want to know the nociceptive, or is the pain nociceptive, neuropathic? If there's a dermatome involved, the severity, what happened, why does he have pain, what is the influence on his life? Exactly, very well.
Mr. Testani also raised his hand.
Okay, feel free to tell.
Also, Dr. Seilani asks, what about previous drugs, drug history related to pain?
Exactly, allergies, other things, experiences with pain, and also with medication. Very well, yes. Well, this patient tells you he has pain in the arm, going through the arm to the fingers, and the pain feels like severe burning, electric shocks. He also has abdominal pain, which will radiate to the back. But then he says his opinion is it's related to constipation. After he went to the toilet, this pain is gone. Okay. What kind of pain is the pain that he is telling you about in the arm? This must be an easy question now. Somebody knows?
Dear Anne.
Yes.
According to the slides that you showed us, it seems that the arm pain is related to some dysfunction of the, vertebral column.
Yes,
Since
and
the pain is radiated from, along the arm from neck toward the fingers.
Exactly. So
I'm waiting. I'm inspiring our audiences to participate in this discussion. Dear Anne, can you see the chat box, or may I ask Miss Samimi to read the answers which is written in the chat box?
Yes, please, can you do that? Because I'm afraid I'm opening something, I'm losing my PowerPoint. I cannot see the reaction,
I will
but
do that.
see.
It's okay, I will do that.
Yeah, thank you.
Thank you.
Somebody reacted?
Message to the Sunny says transfer pain.
It's the
I don't
neuropathic.
understand.
It's neuropathic pain because it's more chances. We go on. What is the reason for the neuropathic pain?
Sorry about the later question. Based on a radiology picture, then it is determined where the area I think is a transfer pain, maybe transfer pain, and is pain not a usual pain, I think.
Yes, what can be the reason for this pain he has?
Because pain in arm maybe transfer to upper and maybe it is not this pain, and I think other pain is the knee area, is the knee area, and maybe in chest. I think, and I think this is not a pain in arm. It is not just pain in arm. Sorry.
Very well.
Yes. I don't know about this history, another, and I forget my answer when I speak. I don't know why.
He had cancer in his stomach with metastasis, and
Yes, of
one,
course.
yes,
This cancer maybe causes chest pain.
exactly. Let's go to the answer. He had a metastasis here, and this was pressuring on the nerves which were going to the arm. So he had a lump, a bump, a kyste was a tumor kyste, which was obvious in his neck, and this was pressuring on the nerves, and you can see the dermatome of the arm was involved. Okay. So he had to go to the CT scan or the MRI to see this was the differential diagnosis. Maybe this is the reason, so we had to check it. What are possible treatments for neuropathic pain, for the pain he had? We have discussed this now, I think, several times, so let's check if you paid attention. Somebody tries?
Dear Anne.
Yes.
If this arm pain is related to the, pressure from a metastatic, lesion on the nerves, maybe, I'm not sure, but maybe a kind of surgery that just is a palliative, approach can relieve the pain. But the other low invasive or non-invasive approaches should be considered. As you said, for example, different kind of medication and non-pharmacological approach like needling or nerve blockade and other kinds of painkiller approaches.
Exactly, yes. It will be a combination.
Mr. Mackey says for severe pain, ROO drugs may be used.
Thank you for your answers. Yes, we should consider radiation therapy, pain medication, non-pharmacological treatments, and psychological or religious support. Thank you for the answer. Very well. What is a possible treatment with medication in this case? So he is going for radiation therapy and we add also pain medication. What will be the treatment that we can use in his case? So he has a tumor and he has a tumor nociceptive pain in combination with neuropathic pain. He has both. So what will be the treatment? What about the WHO steps? Should we use it in this case? Should we use opioids in this case? What do you think? Okay, I will go on because you are too shy, everybody, no? Or maybe you are tired. We are almost done. Let's go. The pain medication in this case will be acetaminophen. For me, it's hard to pronounce. Plus NSAID. We increase the opioids because he already had a fentanyl. And we rotate them to intravenous medication because he's admitted in the hospital. So most of the time we go over to IV medication when people are in a lot of pain because we can adjust more easily the IV medication. When the situation is stable, we go back to the PEDs or the oral medication. We have to take care of an escape for the rapid onset pain, which is typical for cancer pain. So we increase the dosage of the sublingual fentanyl. If the pain is very bad and he is suffering from side effects from the fentanyl when we rise it, we gave him a ketamine IV. This will be done for a few days, a week, and then to wait for the radiation to have effect because he is going for radiation therapy to make this metastasis in his neck smaller, but it will take for around 2 weeks to have effect. Also for the neuropathic pain, we will start an anti-epileptic and antidepressant. And we have to consider to take away this a nerve block, the chordotomy. But it depends on his life expectation, because if we take down his arm, he cannot use it anymore. So it's a very definite nerve block.
Mr. Mahdi asks a question: why do we escape the ROO?
No, we don't escape the ROO. I call it escape medication. So we add it, but it's called escape medication because you have two kind of medications. The slow release, it's giving you continuous pain medication, but there are moments with extra pain, and then we use escape medication. So it's just a name. So we add it. It's not that we skip it or escape it. It's just a name. So we use it for pain moments. Yes? Was that the question or did I misunderstand?
Yes, we got the answer.
Okay.
Dear Anne, I have a question. Since we know that our patient in the progressive stage of metastatic cancer, in real, I'm in clinical, condition, do we have to use acetaminophen or NSAID, which are not so strong?
Yes, we hope it will diminish the use of opioids. It helps, but if it's in use for already a long time, and people are suffering from, for instance, a lot of people have stomach aches from the NSAID, then we skip this. But most of the time, when we raise the doses of the opioids to a level that will be pain reductive in tumor growth, we are so high that the people are going to suffer from the side effects, and then it's helping a lot to add acetaminophen and the NSAID. So we don't skip them, we add them.
Thank you.
Because they all work on different receptors. They all have a different kind of working mechanism. So it helps on different levels to diminish the pain.
Thank you very much.
Yes. Also, we have to think about the non-pharmacological treatment, like non-pharmacological is also giving information, the patient feeling safe, that the treatment plan is clear for the patient. So as nurses, you are a translator from the language from the doctor to the patient also. You should explain, this is going to happen today. This is the plan for the next week. This is your life expectation. Maybe this is done in Holland. I don't know. People know if the life expectation is short because we can help them to think about this short life. What do you still want to do? This was a young man. He had a family, so he had a very, very bad prognosis. His life expectation was less than 3 months. So he had to take arrangements for his family. So it's in Holland, we think it's important that patients know what their life expectation is. And we give them support for this, how to manage this last time. Also, we try to see what is their wish. Do they want to die in the hospital? Do they want to die at home? And if they want to go home, we try to arrange all kind of help, professional help, that this will be possible. This is called end-of-life care, palliative care, and it has a lot of attention in Holland. Non-pharmacological treatment is also distraction, like music, TV. It helps sometimes to have a good friend or family near you. We have virtual reality is coming up, so we have the virtual reality glasses. It gives some distraction when painful injections are done. Resting is also very important. Maybe it helps to put a warm or a cold compress on his neck. Also, we use focus language. It's a strange word, or comfort language. And this is not using words like it will hurt, it will smell bad, but you will say, for instance, we are going to help you. Let's talk about something that you like what kind of holiday did you like in the past? And you will talk about the holiday, or you will talk about his children, you will talk about his favorite hobby, something like this. And you distract the patient, and in the meantime, you will give him IV or you will tell him, but you will not pay the attention to the painful intervention like this. And it's very much used with children. With children, it is working very well to distract them, to read a book or play with something, when on the other hand, something painful will happen. Okay. This is the last slide. Do you have any questions? Because I took a lot of time from you now. We have been doing now almost 2 hours, so I think you are tired, and it's very hot in Iran. Kheli garme unja famidam, shenidam, as Dr. Seilani. I want to thank you for your attention. If there are no questions at all.
Dear Anne.
Yes.
I really appreciate your worthy contribution, and your informative lecture was really useful, and not only informing us about different kinds of pain and their specialized management approaches, but also in getting you familiar with the scope of your practice as a advanced practice nurse, and as a nurse that is allowed to give medication and prescription in this regard. At least for Iranian audiences, I think it's very interesting and inspiring. I think we should move on to this, part of nursing. This is a, part of nursing that you are mostly independent. I mean, you can recognize the problem and decide about the treatment yourself.
Yes.
So, I mean, not only in terms of content, but also in terms of the feature of your work. Your lecture was really informative and useful for us. I just want to say thank you very much indeed.
Mamnoon, thank you. Motashakeram. Thank you for your invitation. I always like it to do lectures like this. So in the future, we can do it again about some subjects related to pain.
Mrs.
If you
Padmos,
like it. Yes?
I'd like to read the message of Dr. Manukian. She says, "Dear Annemarie, many thanks for your brilliant lecture. It was very instructive and I really enjoyed it. Please accept my sincere appreciation for your contribution to this program. I hope we will meet again soon."
Salam beresun be Dr. Manouchian. Merci, mamnoon. Be umide didar.
I also want to thank you very much, Ms. Padmos, and also want to thank our Praise Raise team for supporting today's webinar. And also thank you, Dr. Seilani, and our very good audience. Thank you for your attention and your time.
Thank you very much. Bye-bye. Khodafis. Boos, boos.
Have a great day. Have a great day. Thank you.